morning, ladies and gentlemen. Thank you for involving yourselves so enthusiastically in that opening. I have one more issue of housekeeping just to remind you of before we get started, which is that you'll all have your evaluation forms for this session. So could you, at the end of this session, complete them and hand them in to the organizers at the door. So I am very, very pleased to welcome you to this plenary session, which is on the subject of making health financing for UHC safe. Those of you who are on the ball will remember that yesterday, Professor Maybe, one of the PMAC laureates, also was talking about safe. In that case, that was safe for trachoma. This session is not about trachoma. The session is about health financing. So while we're making lots of progress towards UHC, as we've heard through so many of the sessions here in the conference, more than half of the world's population still doesn't have access to basic health services, and more than 100 million individuals are impoverished from high out-of-pocket spending. To address this, we need to spend more and spend better, and that is going to be the subject of this morning's session. So we're going to be talking about how to make health financing sustainable, adequate, fair, and efficient. And we'll look both at ways to mobilize additional revenue and to spend it better in order to achieve greater health. And we're going to learn from my very distinguished panelists, who I'm going to introduce in a moment. Now, one of the topics we are going to hit upon is digital methods. And to demonstrate our own digital proficiency, we're going to show you that we are not the left-behind generation, and show you I'd invite you to participate in the session through answering some questions using this website, Mentimeter, that you can join either by scanning the QR code or by going to menti.com and typing in the meeting code, which is 499089. So I realize that most of the time in these sessions, we're asking you to put your phones away. Just for these few minutes, I'm going to ask you to pull your phones out to contribute towards this session. So while you are getting logged on and answering a test question, I'm going to introduce my very distinguished panelists. And I think I might ask them to introduce themselves and to say one sentence about their experience that brings them here. I wonder if I could ask you to start, Mr. Shiozaki.
Thank you, Kara. And, I am from Japan, Yasuhisa, member of the House of Representatives, serving there for more than 25 years. And I served as the Minister of Health for 3 years until 2017. Thank you.
Thank you very much. Agnes.
Good morning, my name is Agnes Soucat, and I'm the Director for Health Systems Governance and Health Financing in the World Health Organization in Geneva. And I've spent most of my time working on health financing in different regions of the world, and long time with the World Bank, the African Development Bank, and now in WHO, and passionate about governance and health financing.
Super, thank you very much. Holger, over to you.
Good morning. My name is Holger van Eden. I'm the IMF's Regional Public Financial Management Advisor here in Bangkok for Southeast Asia. I work with ministries of finance here in the region about budget planning issues, public investment, and improving the quality of the budget preparation process, which also involves, of course, to a great degree, line ministries. So we're talking with them how to do more value for money analysis, efficiency analysis, and so on, to review the budget submissions. Thank you.
Thank you very much. Srinath.
Good morning. I'm Srinath Reddy, President of the Public Health Foundation of India. I'm a cardiologist and epidemiologist by training, and a public health advocate by persuasion and passion. I chaired the high-level expert group on universal health coverage for the Planning Commission of India a few years ago.
Thank you. And Lydia.
Good morning. I'm Lydia DsaneSelby from Ghana. I'm currently the Chief Executive of the National Health Insurance Authority in Ghana and the co-convener for the Joint Learning Network for UHC. I'm a medical doctor by profession, and I've been with the organization for about 13 years. Thank you.
Thank you. And good morning. So I'm Cara Hanson. I'm a professor of health system economics at the London School of Hygiene and Tropical Medicine, and I have the honor of moderating this discussion this morning. So now that everyone's got the system going, Fadi, can you please put up question 1 for us? So question 1, do you agree with the following statement? Ministries of health are from Venus, and ministers of finance are from Mars. The implication of this is a bit culturally specific, the implication being that they speak very different languages and come from very different mental models. Oh, so it looks, so this is fun because you can see you can see an early indication and see how the answers settle down. So we can see that actually about 2/3 of the audience believe that absolutely these entities come from different planets and speak different languages. Fadi, question number 2, please. Choose the best method to persuade a minister for finance to spend more on health. So option 1, move too fast. Convincing, I can't, they're too small for me to read. You're going to have to just let them settle down and then I will summarize for you. Not many answers in there. Are you struggling with the technology? It's only 25 or so people who are doing it. Let's let it settle down a bit. I think we're settling into a pattern here. And the pattern is, so the green one, which is convincing analytics showing past effective use of resources, is so far the most popular reason, followed by strong technical arguments showing return on investment, population and civil society engagement, so showing that there's demand for it, and the smallest share here is to a well-thought-through reform plan drawing on international experience. Fadi, question 3, please. Do you think that private financing has a role to play towards UHC? It's quite captivating, actually, how it moves, isn't it? Okay, I think we're settling it down enough here. So we've got really 2 big responses here. 1, yes, governments should incentivize private financing more, or not really. And if so, it should be a marginal source of revenue. So that's quite polarized, interestingly polarized. So we have a substantial middle position there about yes, out-of-pocket payments should be transformed into private prepayment. So those first 3 questions, we're going to come back to this a little bit later, but those first 3 questions are the ones that are going to guide the first half of our discussion. So we'll move on to that. So Holger, I'm going to start with you, because you've seen that a lot of people think that that health is from Venus and finance is from Mars. You've worked for years with the Ministry of Finance. That has been your career. You've been advising the Ministry of Finance how to, from your position with the IMF, about how to contain or constrain public finance. So from your perspective, what are the sorts of arguments that a Minister for Finance would listen to? Do you think that there are certain ways of approaching this argument, or do you think there's arguments that health should never make?
Well, it's a very interesting topic. I think there is definitely a communication problem, but I think both parties can learn to bridge it, right? One of the things that ministries of finance are often confronted with is loads of information about the benefits, the health benefits of the spending proposal. And that's not really the role or the focus of the Ministry of Finance, because the Ministry of Finance receives a lot of priority spending proposals from multiple ministries. So the first thing that the Ministry of Finance would look at, does this fit into your budget envelope in the the medium-term plan, expenditure plan for the health sector. Is the baseline of expenditure under control, or are you facing cost drivers which might actually, prove to increase your existing programs? So I think Ministry of Finance looks first at the overall availability of funds, and later then, I think that was one of the answers of the test was, is the money that is being proposed to be spent, is it really going to be spent efficiently? That's certainly a very important thing. I think we would also look whether this expenditure fits into the reform plan, the restructuring plan of the health system. Look, ministries of finance look at every at every line ministry as having a lot of inefficiencies. And if you've read the literature on healthcare spending, then the estimates for inefficiency in the healthcare sector are up to 40%, right? So a minister of finance talking with the minister of health, talking with the minister of finance, should start with discussing the global picture. Yes, we're on track with our planned reforms. Yes, we're on track, our baseline is under control. And then I think you have to discuss the project itself and show, value for money, efficiency, and so on. So I'll keep it at that for this moment.
Okay. So you did start there by saying that ministries of finance don't care about health. So that's quite an interesting, so that is definitely a Mars-Venus issue. So they're interested in efficiency and making sure that we stay within the overall budget envelope.
If I said that, that was misspoken. Look, they care about health and they care for the health impact of expenditure, but their primary role is to look at the bigger picture of available resources. Yeah.
So they have difficult decisions to make as well, prioritizing across different sectors. Mr. Shiozaki, you have a very interesting experience because you've sat at both sides of the table. So you've sat both on the health side and on the finance side. So was there anything that you learned from your experience of being the finance minister, the vice minister of finance, that influenced how you took your arguments to the table when you were the health minister, trying to generate the resources that you needed because of the growing demands on health in Japan?
Yes, I had a rather unique opportunity of serving as a health minister for 3 years. But even younger period, I served as a vice finance minister. And by the way, my father used to work for Ministry of Finance, so I can compare the culture, language, and the perspective of those ministries. And I think as I spent 3 years in the Ministry of Health, Labor and Welfare, I really thought that we have to have evidence to convince Ministry of Finance, and any policy measure could end up with fiscal gains in the longer run. And the point is how and in what way we can successfully convince the Ministry of Finance. And the Ministry of Finance is always trying not to think about long-term solutions, but only for short-term solutions or fiscal year budget. And but we are not living only 1 year, each year, but we have a long life in front of you. So the responsibility of Ministry of Health in order to address to Ministry of Finance for new investment in health, we have to really prove that the fiscal, from fiscal consolidation point of view, we can successfully come with the right solution. And in the case of TB, fight against TB in Japan in 1950s, that was a good example for making or bringing free screening by taxpayers' money, and also free TB treatment and inpatient in the cases in the hospital, and also almost very humble outpatient treatment affordable by putting taxpayers' money. But at that time, the our economic development stage was going to grow at that time, and by making patients to treat and back to the labor market, that end up with the more taxpayers from tax spenders, that really satisfied the Ministry of Finance in the end.
That's interesting. So the broader economic impacts of health, thinking about the effects on labor force productivity and labor force participation, would be a particularly persuasive argument, you think, for the Ministry of Finance. Srinath, we heard this week from the Director General at WHO that the real threats from the current coronavirus outbreak is for countries that have less strong health systems. If we take your country and we take the metric of public health spending, so India spends about 2% of GDP on health, which is low by international standards, that's the sort of place that might be vulnerable to the outbreak. Do you think that this crisis offers some opportunities to those who would advocate for greater health spending in India?
Certainly, some of these pandemic threats are a wake-up call for strengthening the health system. If the health system has to be functioning well in order to respond to a pandemic threat, it has to have a steady state level of efficiency as well. It cannot just wake up and respond. So the important message even to finance ministers is that we need a health system that is efficiently functioning so that it can firstly prevent or quickly contain some of these pandemic threats. And even responding to the question of efficiency gains, we do need front-end spending in order to enable health systems to optimally and fully utilize the health financing. An underfinanced system which is feeble will not have the capacity to absorb and utilize the funds. So some front-end spending is required. That's the message that must go to finance ministers. And if our primary healthcare services in particular are strengthened, then the ability to contain this epidemic becomes much stronger. If the fire extinguishers in primary care are functioning well, then you do not need a panicked pandemic response of fire engines rushing everywhere with their alarm bells ringing.
That is a very powerful metaphor. Nobody has really spoken very much about public demand and trying to use the political economy arguments for greater spending. But do you think, Srinath, that there's things, if you think about your role as outside government at PHFI, are you think that there are things that citizens and civil society organizations, media can do to influence politicians to see that argument, both for the front-end spending to strengthen the system so it's better able to respond to crises?
I think there is episodic outrage in the media and, of course, articulated well by the civil society whenever there are some disasters like children dying in hospitals in larger numbers than they should, or some outbreaks are not contained quickly enough. But I think this needs to become a sustained campaign, and there are many arguments that need to be made. Firstly, of course, the rights argument that everybody needs health care and that the governments cannot fail them. But secondly, even from the point of view of India's current demographic position, there's a powerful argument to be made to the finance ministers that there's a great employment potential to utilize the demographic window of opportunity. India has a young population and will have a young population for the next 2 to 3 decades. And even when employment opportunities are shrinking in technology-driven industry, agriculture, and service sector, the health sector offers a huge employment opportunity apart from serving the health system needs. So these are the kind of arguments that we collectively need to put together. But certainly, whenever there are health disasters of suboptimally rendered health care, resulting in large number of children or infants dying, obviously that's an opportunity to press upon the government that you cannot afford to have weak health systems.
So there potentially is an opportunity here to not to waste a good crisis. Okay, we're going to shift gear a little bit and move on to our kind of second topic for discussion, which is really about how to fill the gap in spending. So we know that there's many institutions have produced estimates of what's needed in low and middle income countries to achieve the SDGs and to achieve UHC. And even with their very best efforts, it's likely that, that public resources are not going to be sufficient. So even if tax revenue can be increased and allocations to health can be increased, there's going to be a gap. Holger, could I ask you to speak a little bit about what you think the options are for filling that gap and to think a little bit about what the role for private financing might be?
Yeah, well, the IMF has made a number of calculations on what the costs of the SDGs would be for the various sectors and in total. By the way, I would agree that in the healthcare system, but also other systems in developing countries are underfunded, and that can lead to inefficiency by itself, right? People are just not equipped with the right tools to produce that efficiency. So, our view is that in a number of countries, spending is inadequate, right? And the SDGs kind of indicate that. So the estimate is, that the SDG cost for low-income countries would be something like 14% of GDP, and for emerging markets, 6% of GDP to be spent additionally on an annual basis by 2030. And a large part, especially in emerging markets, of that funding gap is the healthcare sector. Now, one of the things that the fund has been pushing, and also the World Bank, is to increase revenue collection in countries. We think that a number of low-income countries and emerging market countries, the public sector is too small. And so there have been revenue mobilization efforts set up in countries to increase, and the target is over 10 years, a revenue mobilization of 5%. So if the public sector is like 12%, 15%, that would increase the size of the public sector considerably. But if you see the gap of 14% and 6%, then you also see that revenue mobilization is likely not going to fill the total gap, and other sources like official development aid and borrowing are constrained. Official development aid hasn't grown for the last 10 years. A lot of countries are are up to their debt limit, in a sense that they want to have sound and stable fiscal conditions in their countries. So that what remains is private financing. So we do promote and are engaged with countries on how to provide more PPP financing for certain sectors, right? But also in the healthcare sector, what can the private sector provide in either insurance or in fee for services arrangements. And so, if you look at the total picture, I think the private sector has to be included in bridging the gap, the financing gap.
Mm-hmm. Thanks. I think it's clear that the gap is there and that the private sector needs to bridge it, but actually there are some risks attached to each of those things, aren't there, in terms of bringing in public finance to finance capital, or we know that private out-of-pocket payments are also a risk to the health sector, and certainly are known to drive catastrophic payments. Do we know anything about other ways of harnessing private finance, or is that going to be a system issue that we'll leave the health people to worry about?
Well, I agree that there are risks. I mean, the PPPs usually have a higher rate of return than if projects are financed just by, government borrowing or by financing from international financial institutions. So, the costs and the risk distribution of PPPs is certainly a concern for public finances. And you know, on private contribution to healthcare services, I think there are risks that if it's not done well, it will actually shift resources away from the public sector. Yeah.
So Agnes, I'm going to turn to you on this one. So we're worried that the private sector is both the answer, but there's a risk that it's going to be more of a problem. So do you think that there are things to do with public policy to shepherd these resources so that they actually help solve the financing problem rather than increase and drive the problem?
Yes, absolutely. And actually, this is the fundamental question, the question of public policy, because the private sector is here. We sometimes hear in different fora that how to attract the private sector in health, but the private sector is a current reality. In fact, if we look at the global spending on health, but WHO published a report recently on a world in transition when it comes to global spending, what we see is, in fact, private spending has kept increasing over the past 2 decades. And the share of the health economy in the global economy is increasing. It's now 10% of the global economy. And even in the developing world, in low and middle income countries, the health sector grows faster than the economy. It has grown at 6% per annum, whereas the economy overall has grown at 4%. So, in fact, the private sector is here. It is investing in the health sector. We see that it's actually one of the most attractive sectors for investment. It's a sector that creates a lot of jobs. And what we see, even if public spending is increasing faster, and even in countries in which there has been a massive increase in public spending towards universal health coverage, even in those countries, private spending continues to grow. And sometimes there is a misleading picture because you see overall, as a proportion of total spending, you see private spending declining because public spending increases faster. But it's because it increases faster, but private spending continues to increase. So private spending and private investment in health is actually a fact of life. And we know that today in the world, with poverty declining, with the world getting richer, that in fact there is a lot of capital around looking for good investments. And that's the question. That's the public policy question, is how do you shape the market? How do you shape these investments in healthcare? And the public sector, governments have different tools that they can use for that. They can have investment policies and a vision about what they want the private sector to do. I think the vision is extremely important. The overall policy, and different countries have chosen different approaches to it. Do you want the private sector to do give certain type of care? So what we typically see in Western Europe, the private sector being sort of given the niche of the kind of services that are quite common, but are easy to monitor. Appendectomy, hip replacement, some primary care. It doesn't mean that these services are privately funded. They can be publicly funded, but they can subsidize some private provision. That's one example. In terms of investment policy, PPPs, Holger just mentioned, it's blended financing in general. There's been a lot of studies about it. It can be useful, it can be very risky for government because it's all about how you structure the contract. But we know that what the private sector wants, it wants stability. It wants long-term, a long-term stable relationship with government, particularly because the health sector is mostly about recurrent cost. So they're willing to invest, but they want to know who is going to actually cover the recurrent cost over time, and may be interested in long-term relationship in which there is a public subsidy to their services. And that's a bit the difficulty of structuring this contract. And of course, they are really the fundamental instruments that government have, which are regulation. Regulation is terribly important, and we see that here we often have a quandary in the developing world, in low-income countries and in some middle-income countries, in which health systems have been built on the provision function. So ministries of health know how to provide services, but they haven't really spent enough energy, attention to developing the regulation function. And that is really, really essential. Developing accreditation, developing monitoring mechanism, developing the data system that allows to monitor the contracts is extremely important. But I would really emphasize in concluding the importance of a vision, that there is really a clear view of government of what they want the private sector to do, so they can really decide how they incentivize, how they shape the market, how they really use all the instruments they have to involve the private sector.
That's so interesting, because it really sort of presents in sharp contrast to the experience in many countries where the public sector has kind of stepped aside and let the private sector go. So having that vision, having that ability to shape and get what you want from the private sector rather than allowing it to follow its own direction is really important.
Very much so.
Yeah. So Mr. Shiozaki, so we know on the financing side that out-of-pocket payments are a problem. They can be a barrier to access, particularly for the poor, and they can create problems especially for people with chronic conditions. Do you see any role for co-payments and for ways to minimize the harmful effects of private co-payments?
I think the composition of private financing and public financing varies by development stage, and also the social determinants of health and all that kind of stuff. It really influences what kind of composition of private financing is the ideal at that time. But learning from our experience, I think there are a couple of lessons we have to share with you the main message is, don't think about just now, but look forward maybe 30, 50 years ahead. That means the change in demography in Japan. I think we miscalculated to come up with the rather wrong solution on the out-of-pocket payment for the elderly. In 1970s, we lowered this out-of-pocket payment for seniors to 0, and it took almost 30 years to bring them back to appropriate level, which is now we are now implementing. But as aging proceeds, we have to change it even more suitable for the new democracy and also income distribution of the seniors. And we are trying to, we just decided in December last year, only a month ago, that we're going to raise the out-of-pocket payment from 10% to 20% for age 75 above. But we haven't really decided yet what proportion of population over 75 will be levied 20% yet. We have to decide it by June. But anyway, what you should all learn, if you are still thinking about only lowering the out-of-pocket payments, don't lower too much. And think about the demographic change, and you should have concrete, solid evidence with future forecast. And politics might stir up that kind of discussion, but I think policy must be made on the basis of evidence.
Okay, thank you. So we're going to move on then to our second main topic, which was, so we've talked mostly here about raising more money and the options for raising money, some of the ways that health ministers can navigate the discussions with finance ministers to try to talk to those Martians about what sorts of arguments we can make for health, from the Venus perspective. And we've talked a little bit about what the role of private spending might be. And I think that issue of having that overarching vision, and as Mr. Shiozaki reflects as well, making sure that vision has some time to it, has a time perspective on it, is really important. So planning the system that we want to have over time rather than worrying only about short-term interests. We're going to move now to the second half, which is about spending better. I'm going to ask Fadi to put up question 3. So you're allowed to get your phones out one more time. And question 3 is going to be about priorities for public spending on health. So here we're in a world where we're saying spending more on its own is not going to take us to UHC. We have to spend better, use scarce resource well to meet major resource needs, and that there'll be some pretty important trade-offs here. And so the question is about how do we trade off amongst issues of improving equity, improving financial protection, improving health security, and funding core public health services to prevent disease outbreaks. Oh, this is a really interesting format here. So we see some bubbles emerging across these 3 priorities. So it definitely looks like the priorities are being expressed, despite the immediate risks, are being expressed in terms of ensuring that public spending meets the needs of the poor to reduce unmet need, and to about evenly split between that and financial protection to prevent financial hardship. Okay, thank you for that. The other thing I'd like to tell you is that the next thing that's going to come up on your phone is a way for you to ask some questions to the panelists. So I'm going to ask some questions about setting public health priorities, but you can ask questions using your phone across any one of the 4 themes that we're going to talk about. Those will be moderated, and we'll come to them at the end of this discussion to give you a chance to ask some questions of your own. So I'm going to first ask panelists about how to spend better on health and improve value for money. And Lydia, I'm going to start with you. So you are the CEO of Ghana's National Health Insurance Agency, and you have some interesting controls and powers and levers as you're a major purchaser of health services, and you have access to great data. How do you use that data and your purchasing levers to help reorient the system towards a more primary healthcare oriented model?
Thank you. The thing about Ghana's health insurance is we have earmarked funds, a special health insurance levy. But to pry that money out of the hands of the Ministry of Finance is the challenge. And as other speakers have said, it's about showing value for money and good use. So for us, we have to use that data, one, to show what the efficiency gains are within the health sector, but also to better use whatever money we get to get even better health outcomes. And what we have found from looking at the data is that we spend so much on curative care. I think the top 15 hospitals in the country use about 60 to 65% of the fund money, and that just isn't acceptable. The bottom 50% of the facilities are using less than 20%. So this data needs to help us change the health-seeking behavior of our citizens and move them to the primary level and begin to change our attitudes from seeking care when sick to keeping healthy, so that people maintain prevention and promotion and change the whole mindset around how Ghanaians look at health. If we can get them to go early, thinking more about keeping healthy, then we don't spend so much money on the curative aspect at the higher levels of care. And I think that's what what the health insurance is trying to do. Ghana is using the health insurance as the accelerator towards UHC. We hope to use ourselves as the catalyst to drive the country towards UHC. And this is one of the areas we hope that we can refocus the priority, and that will in turn convince the Ministry of Finance and the policymakers to change what is happening in Ghana.
So Lydia, you've talked about your data sources, so as a way of understanding the current patterns and monitoring changes in patterns of care. But you're a purchaser as well. You have tremendous opportunities to shape the way the system works. So how are you going to use your purchasing levers to shift towards greater PHC focus?
Yeah, obviously we use our provider payment mechanisms, gatekeeper policy, referral systems, and try to pay at the primary care level to avoid people going to a tertiary or a teaching hospital with malaria, diarrhea, etc. But the health insurance and health is very, very political in Ghana. We are in an election year, and the public, because they pay this health insurance levy, actually have a very vested interest in what happens in the health sector, and they can really drive change. So as the health insurance agency, we actually do roadshows with the public as well, and let them understand a lot more about how the money is being spent. We work very closely with the main service provider, which is the Ghana Health Service, and together we then drive the political change to get things done.
Thank you. Agnes, you sit in a global health institution. Where do you think the priorities lie for public health spending? How do we spend better the public money we've got?
I think we need to have a very clear message on this, and I think the evidence is increasingly here. The priorities for collective action, for public action, should be first and foremost where the market fails, where individuals fail, and we need collective action. So the first priority should be public goods and the large market failures. And we in WHO have sort of collected that with a group of experts into the fundamental concept of common goods. We just published a special issue of Health System and Reforms on financing common goods. And it's really the step zero of UHC. And we see it today with the epidemic of coronavirus. Is the first thing that governments need to invest in are those core functions, those core public health functions, the surveillance, the information, the regulation, the policies, the fundamental disease control programs. And this really has to be the first thing, because since it's a public good, it's fundamentally equitable. It reaches everybody. And when governments don't invest in common goods, the first that suffer from it are the poor, the most vulnerable, those who are most vulnerable to large risks, environmental risks, disease risks, because they don't have the means to actually escape the common fate. So we really need, that's for epidemic preparedness, that's for communicable disease, infectious disease prevention. That's also for prevention of non-communicable disease, something like the health taxes, taxes on tobacco and alcohol and sugar and sweetened beverages. These are actually financing instruments that not only don't cost, but they actually bring revenue. So there are multiple wins there. And really the investment in regulation of this private sector that continues to grow. So this is really the step zero. And then we really need to emphasize the equity message in the step one of UHC. It is about, first and foremost, delivering basic services, delivering a package of services to the poor to address two market failures, the equity issue and the failure of insurance market. Because we know that no country can reach universal health coverage through private insurance, because they are the preconditions that people who will have particular vulnerabilities will not have access to that market. So there are really a lot of fundamental reasons for governments to give priority to health, but they should really be in that sequence. First, common goods. Second, the equity argument that plays both on the access to services to the poor, so the poor need to have access to the very cost-effective interventions that are available today, can be delivered at very low cost, and we know that there is a series of interventions that most countries can fund, and also ensuring that basic safety net of financial protection for the poor so that there is no impoverishment that is linked to healthcare, because we also know that there are a lot of benefits on social welfare for governments to do that. So the health insurance function, the role of government in providing safety net on catastrophic expenditures, the role of health insurance is a fundamental function of government in terms of ensuring safety nets for the poorest population and the middle class.
So that also speaks to sort of a PHC orientation as well, looking at where the levels at which services are delivered most effectively and cost effectively, and where they're going to reach the poor. Srinath, the Indian system is very hospital oriented, and how do you think that India can go about shifting towards a more PHC focus, where it will address those functions, the sort of the preventive, promotive, surveillance, public health, equity, primary care focus?
Well, there is actually a shift happening at the moment with a fair amount of commitment now to comprehensive primary health care. Of course, that needs to be translated into effective functioning health services. But clearly, primary health care addresses all the three dimensions in the WHO cube. It is serving everybody in terms of population coverage. It is providing the broadest package of health services, service coverage, and it is the most cost-optimizing element and can reduce a great deal of out-of-pocket expenditure, which in India primarily derives from outpatient care. So in all three dimensions, primary health care services score the highest. So that is the argument that we need to push forth. Secondly, it is going to be the most equitable from every sense, because it's going to provide the poor a whole bundle of services that they have not been able to get so far. Of course, along with that, we also need to strengthen our district hospitals and emergency healthcare services. I believe while choosing the package of services, we need to look at horizontal equity, where everybody in the population gets the basic essential package of services. But then there are additional elements for vertical equity to bridge the health equity gaps, for prioritized provision to the poor with increased resource allocation or an augmented package of services. But for primary healthcare services, it has to be universal, and that is where I think the UHC package has to begin.
Thank you. So that kind of gets us, so we've talked a little bit about the issues of allocative efficiency and getting monies to the right things. But of course, the other way to spend better is to generate technical efficiencies as well. And Lydia, I know that you've got some interesting examples of mobile technologies and interoperable IT developments to help improve the operations of the insurance scheme. So looking at enrollment and looking at fraud control. Can you tell us a little bit about that?
Thank you. We use a biometric card to be able to access services, and it's an annual renewal with about 65% exempt from premiums. But just going to renew your card annually was a huge barrier for renewal, especially the informal sector. Every hour spent queuing is an hour not earning money. So using design technology, we talked to our members, and they wanted to renew themselves somehow. Now, everybody in Ghana has a mobile phone, even in the most rural areas. So we're using mobile technology to renew, and if you need to pay a premium, use mobile money. And because of that, the hospitals now authenticate every visit using mobile money. So we now have real-time utilization data, demographics of who goes where at any time. But we added another step where the members receive an SMS with the name of the hospital authenticating them. And if you are not at the facility or haven't been there, you just press the number 2. And somehow that caught up the public's imagination. First of all, the number of claims coming through has reduced a little because the providers have to authenticate and get a claims check code. But the public have become very interested, and members have shut down 2 facilities because, you know, in that locality, they kept receiving SMSs when they hadn't been there. And they actually confronted the doctor and locked up his hospital, which is interesting for us because, as I said, it's very political. And people feel if they are paying a levy, they want to see the money used efficiently. And they feel they've been given a voice in how the tax money is being used to provide care. So it's sort of interesting dynamics all round.
Sounds fascinating. So technology is a way not just of improving efficiency, but actually strengthening governance and accountability and having a bottom-up check on the potential fraudulent behavior by the providers. So that's really interesting. Srinath, you know, India is a big tech hub. I know that many of your colleagues of PHFI have been working with different digital technologies. Where do you see the opportunities and maybe some of the pitfalls?
I think it's absolutely important to leverage the strength of technology for providing greater access and improve affordability of services across the board, but particularly in primary health care. And that's where my colleagues in PHFI have been focusing, engineers and public health experts working in tandem to produce those kind of technologies. Point-of-care diagnostics have been produced for improving diagnosis and follow-up of people for antenatal care in Jammu and Kashmir with excellent benefits. Now, decision support systems and point-of-care diagnostics have been developed with handheld tablets for diabetes and hypertension and have been utilized for training and deploying auxiliary nurse midwives on large scale in a district in Himachal Pradesh with excellent results of a 15 millimeter reduction in systolic blood pressure, 50 milligrams per deciliter of blood sugar reduction sustained over 18 months. And this program has now been adopted by the state of Tripura for statewide implementation. So we are now seeing a large number of technologies that are being developed which can enable frontline health workers to play a much stronger role, especially the non-physician healthcare providers, and reduce the dependency on a doctor-centric system.
So really interesting. So ways of technologies to help not just efficiency and accountability, but quality and coverage of essential services as well. So I've kind of worked through all my questions, and I'm hoping that those of you who have been on Mentee have been asking some questions at all. And my very able organizers here have been looking through them and are going to ask a couple of questions on your behalf. So Joe Cutson is there, one of the session organizers, and he's been monitoring, and he's going to ask some questions of the panel.
Yeah, thanks. We've gotten a lot of good feedback on this, a lot of questions, a lot of controversial comments made, and so we did our best to kind of crystallize these down to 3 questions for the panel to consider. A lot of people responded to Mr. Shiozaki's comments about co-payments, and really the question there is, why should we not keep co-payments low? Because this seems to be arguing that the sick should pay more, and especially if co-pays are defined as a percentage of the charges rather than in some other way. Second, again, going back to one of the questions that was for the poll, was how to manage the trade-offs between the aim of financial protection against high-cost care versus equity and service use, particularly in relation to primary health care. And then a key question is, what do you see as the role of civil society to ensure that there's a reasonable level of government spending on health in low and middle income countries?
Okay. Wow, 3 questions and 5 minutes. So, Mr. Shiozaki, that question about co-payments, I think was to you, but I might ask others to kick in as well. So you were kind of talking about the value of co-payments as a way of controlling utilization, but do you think that runs counter to equity, particularly if co-pays are a share of total cost?
As I said, we are trying to raise the co-payment of elderly over 75 years old sometime from maybe next or another year ahead, but from 10% to 20%. But also, as I said, I think it all varies country by country, and income level and income distribution, inequality, and all that, and should be taken care of. Even in our case, of course, we do ask for as many co-payments as possible equally, but of course we have to care about the really low income bracket people, and we often waiver or pay less for that. And so the combination must be politically agreed upon through the process of the combination of private and also public financing of medical services. But at the same time, of course, we have to always make medical services efficient enough not to pay too much without any purposes, and so that we will, of course, have to utilize maximum. We should introduce maximum use of technological innovation all the time. Although in some cases, medical doctors are against, oftentimes, for online consultation from the fear of losing their patients by doctors in Tokyo or something like that. So I think for both sides, demand side and supply side, we always have to streamline, and we will ask for the minimum co-payment.
Let's move on to the second question then, which was about this trade-off between equity and ensuring access and financial protection. Who would like to jump in on that? I can see Agnes moving. Do you have some insights into how that trade-off could be made in a way that is fair?
Well, we certainly have looked at how countries look at this, because it's the trade-off that every public policy maker has to face. And in fact, I think we can identify 3 main ways of looking at this. First is really looking at the value for money. So it's all the efforts that have been put in identifying what works and what doesn't work in healthcare, and trying to channel the public subsidy to sort of high value, high effectiveness, and reasonable cost interventions, and making sure those are delivered. I think the second effort is really the integration of services, and all the movements that exist around people-centered services, so that you really make sure that people have access to services at an early stage and benefit from promotive and preventive services and whole-of-person care before they get into sort of high-cost intervention. And the third one, which is the most powerful instrument and applies to the first 2, is really the using the subsidization, using the subsidy instrument, and playing with the level of subsidies, which actually is the other side of the coin of the co-payment. Is you play with the subsidy, you play with the co-payment. And typically you would see that countries who have a high level of performance, they put a high level of subsidy at both ends. They put a high level of subsidy on very high cost care, so that people don't experience financial hardship when they have to face cancer treatment, for example, so it would subsidize effective cancer treatment, effective chronic disease treatment. And on the other hand, fully subsidize the promotion, fully subsidize the public goods, the goods with the common goods with fundamental market failures, and then in the middle play with the co-payment aspect. So that's sort of generally what we found are the strategies that countries are using.
Okay, thanks. We have one last question then about the role of civil society. Srinath, do you want to jump in on that one?
Yeah, we frequently talk about the co-creation of health and people's role in it. I think people also have a role in co-creating efficient and equitable health systems. And that is where actually the civil society can play a great role in mobilizing, monitoring, and in managing to some extent and mending when there are problems. So clearly we are talking about the role of the civil society as a watchdog, but also in mobilizing the people for appropriate participation in the whole endeavor of accessing and delivering universal health coverage. So we need the civil society for mobilizing citizen power as well as citizen participation.
Thank you. So I'm going to draw this to a close. It's been a really rich discussion, so I'm kind of reluctant to think about summarizing, but I think it leads us all very nicely into the next session. We've talked about how UHC is not just about spending more, but about spending better. You can't just spend your way to UHC, as I've heard Agnes say many, many times. That it's a complex set of issues, but I think it's also important to remember that we're not starting from nothing. There's actually a lot of experience and a lot of technical principles to guide the design of these systems. I think making sure that we're building systems on those firm foundations is important. And I think this idea of language is really important, that different organizations use, or different institutions in this architecture use different language, and learning to speak the same language to bring the sides together will be really important as we try to both spend more and spend better. In fact, use our language of spending better as a way of creating the opportunities to spend more. So before I thank the colleagues, I would like just to remind you about the next the next session, which will be a session of parallel sessions on these same themes, so looking at fiscal space, about digital opportunities, purchasing, development assistance, and assessing health interventions. I would like to remind you to please fill in your evaluation forms as you go out, and then I would like to ask you to join me in thanking our very excellent participants and discussions.